We have today four speakers. One may join us quite soon. We will start with Dr. Hailay Abrha Gesesew. He's a senior researcher, research fellow in Torrens University in Australia. He's an Australian citizen, but originally from Tigray, and he's got family in Tigray. Conflict and health is one of his research interests, and he will be presenting on the impact of the war in Tigray on its health infrastructure, personnel, and main outcomes. Dr. Hailay, the floor is yours.
Thanks, Ani. Thanks for the introduction. I think I will share my slides for the presentation. Can you see it?
Yes. Make it full screen, please.
Yep, good. Can you see the second slide as well? Or is still in the first slide? Second slide, honey, sorry.
It shows the acknowledgement. If you can go to the first one.
Yes, good.
Yes, perfect.
All right, thank you. Thank you again for the introduction, and thanks everyone for coming, and thanks Mr. Altaf as well for in short notice. So you know, as in Australia, we need to acknowledge the land we live. So I will begin by acknowledging of the country, and I begin by acknowledging the traditional custodians of the land on which I meet today, and pay my respects to their elders, past, present, and emerging. So, like I said, I will be presenting on the impact of the war in Tigray, particularly on the health infrastructure, on the health workers, as well as also their implication on the main health indicators. And I will be winding up my presentation by just saying a few points on call to action. But at the end of the presentation, I expect at least you audience to have a fair understanding on the scale of the damage, as well as also I expect, you know, what could be a discussion on what could be the call to action points, and in fact, on the task to stop the genocide. It meant, you know, the first presenter will be presenting the context, so probably you will see it later, and you will see how it's genocide. So I, at the end of the presentation, I think I want to a task to take a task to stop the genocide. So I will leave the context to Dr. Hayes, and I will directly go to the presentation in relation to the impact of the conflict on health. So basically today's presentation, my presentation today will be based on a preliminary findings of a systematic review that I am leading. I am leading a systematic review on the perilous medicine in Tigray, and that basically will follow a Delphi technique. And then finally, we will try to suggest a future research agenda in regards to conflict and health in Tigray. So the main findings today will basically be based on the findings from the 33 records that are published in relation to conflict and health in Tigray. And as you can see, the great majority of them are either, you know, commentaries or full original peer-reviewed articles. And the great majority of these findings basically are published in one of the highest or the most impactful medical journals, including the Lancet, as well as also the British Medical Journal. So what I am going to present basically are based on findings which are published in this highly reputable journals. So what's the impact of the war on health infrastructure in particular? So before the start of the war, Tigray has more than 1,000 health facilities, of which it includes, for instance, some 740 plus health posts, which used to give community health services. But as you can see, more than 80% of those health posts are either damaged or looted, be it partially or fully. And out of the 230 plus health centers in Tigray, 3/4 of them are now fully or partially damaged or looted. By the way, the health centers in Tigray actually deliver services to almost 85% of the population. So you can imagine, the 3/4 of them are either fully or partially non-functional. And in fact, the fully functional ones basically are out of stock. So it's just very easy to imagine what will be the impact. And out of the 40 plus hospitals in Tigray, again, more than 80% of them are actually either fully or partially damaged or looted. There were about 280 plus ambulances in Tigray before the start of the war, and there were about 90% of them are unknown. Some of them are burned, some of them are looted. And like I said, even the remaining ambulances are not fully functioning because there is a shortage of fuel. So it's basically in a very precarious situation. So all these magnitudes are based on the data from the Tigray Regional Health Bureaus, as well as also MSF, who is to actively work in Tigray during the conflict situation, as well as also some other resources published in those journals. Now, I tried to quickly compare, the level of damage with other conflict settings, and there is nowhere to such level, to the level of 80% of the health facility, damaging of 80% of the health facilities. The one with the highest was in Bosnia, which was damaged by the Serbian forces. It was nearly 50% in 1994, but the Tigray one is just way high, that one. That's why it's just very easy to guess.
Dr. Hailay, your voice is a little bit cutting. Can you use a microphone if possible? If this will not result in a delay.
Okay. Let me use a headphone in case. Can you hear me now?
We do hear you.
Yeah. It might be my internet connection. So just...
Oh, okay. Go ahead. Thank you.
Yeah. Well, apologies for that.
Yep. So, and like I said, so that 80% plus damage, literally shows that the health infrastructure were targeted, and you can't say, such a huge number basically is just collaterally attacked. Now, the impact is not only in the health infrastructure. So if we see in the health personnel, for instance, there were, before the start of the war, almost more than 25,000 health workers were on duty in all the health facilities that I have mentioned before. But after the start of the war, for instance, in April 2021, like half of them didn't report their normal duties. A year after, in May 2022, only 1,300 health workers reported in their duty. This was actually published in the Lancet journal. This is not that surprising because, since June 2021, none of the health workers were paid their salaries. Well, they can't use their savings as well. So, from the outset, you can see if none of the health workers, didn't pay their salary, for more than a year, it's just a clear targeted attack of the health workers. In fact, as a result of this, many health workers were displaced. For instance, in a single IDP center in Mekelle, almost 2,000 health workers were registered as refugees. UN also reported a stories of a surgeon, a Tigrayan surgeon, fled to Sudan. So some of them are just flew, some of them are displaced, and not only displacement, but there were also reports that health workers were also killed. We heard MSF reported the deaths of 3 staff. United Nations reported the deaths of 26 aid workers. Tigray Regional Health Bureau reported the deaths of 37 health workers and plus 78 injuries. And a couple of days ago, Red Cross also reported the death of a driver. So you can see how the health workers were also targeted. Now, the targeted attack on the health infrastructure, as well as also on the health workers, lead to the collapse of the health system. And given, as most of you know, that Tigray is under blockade, under a complete siege that includes medical siege, it's just very easy to guess how the health system would be so collapsed. So the collapsing of healthcare means that like the availability of essential medications are as low as, for instance, below 20% in 2021, and it's just dwindling every time as it goes. And that means to the extent that there is a shortage of gloves, there is a shortage of gauze. We saw, probably Dr. Fasiga will tell us later, health workers in either referral hospital were washing gloves in order to reuse it. The health workers were using a white cloth, by asking their patients or by traveling to churches in order to replace the gauze while they do the surgery. In fact, medieval surgery, if I use the word of Dr. Fasiga. You can imagine, the persistent interruption of the electricities on the routine function. Think of the cold chain, think of the anesthesia, think of the surgery with a frequent interruption of the health, the electricity. And yes, because it is medically besieged, there is a shortage of insulin for diabetes patients, there is a shortage of antiretroviral therapy for HIV patients, a shortage of oxytocin for pregnant women, a shortage of oxygen for patients who are admitted in ICU centers. So all this leads to a poor indicators of health outcome. All this leads to a needless death every day at different age groups. So the collapsed health system, for instance, if I just try to show you the snapshot of the health outcomes, for ANC dropped down from 94% before the start of the war to 16%. Skill delivery from 80 to 20%. That's why you can see such a significant declining of the maternal services directly impacted the maternal mortality, which automatically doubled after the start of the war, which is at the end of 2022. Full vaccination rate goes down to 27%, and this leads to the outbreak of vaccine preventable illnesses. If you just quickly see, based on a letter written from Tigray Regional Health Bureau to Gavi, in fact, which was CC'd to WHO and UNICEF, you can see all the types of the coverage of the vaccination is just very, very low. Malnutrition is skyrocketing from 32% to 78%. And that's why almost 500,000 children in Tigray are malnourished, which means they are at the brink of death. I can go and don't go on with outcomes, including the heinous crimes of rapes, which I don't have a courage actually to present the characteristics of the rape. So what's happening with the health system is just so horrendous. Is it because with regards to the chronic health patients with chronic health conditions, there were more than 180,000 patients with chronic illnesses who use it for written follow-ups, including, more than 25,000 of diabetes patients, almost 30,000 of hypertension patients, more than 45,000 of HIV patients, and so on. And sadly, we couldn't get the full information. For instance, in 2021, there were reports of thousands of patients with diabetes, thousands of patients with hypertension, and based on a quick snapshot of patient record assessment, for HIV, for instance, almost 80% of them were lost follow-up. And I guess the mortality rate of HIV without treatment is very high, especially in a situation where there is no adequate food, in a situation where there is no adequate treatment for opportunistic infections. So the outcome is just so gruesome. Now, with the interest of time, I think probably Hayes will present on what exactly is happening now in Tigray, but I will try to quickly read what's concluded in the Lancet infection, and I will leave the ones in the United States, with the United Nations, that they concluded the systematic attack leading to genocide. And most of them know what Dr. Tedros has been saying. So the one in the Lancet infectious illness, it says it's impossible to know exactly how bad things are in Tigray. Internet services have been shut down. Telephone lines were cut off in since June 2021. And the federal government in Addis Ababa imposed a punishment blockade, and the vast majority of the 7 million people are struggling to find enough food, and almost 500,000 children are thought to be malnourished. So that's the situation, what's happening in Tigray. So yeah, with the interest of time, I guess I will try to conclude with the call to action for every one of you. Now, I think you can have a fair understanding that the health facility, as well as also the health workers in Tigray, are targeted, not collaterally attacked. And this means that health system in general was used as a tool of war. And in fact, this was part of the ongoing genocide, even though it's not, if it is not officially declared. I guess we have a representative of WHO as well as also PHF here. So I think it's important to keep putting a pressure on the key stakeholders, particularly on the United States and the EU, in order to stop the war in Tigray. It could be through different means, and the people definitely need some medical supplies. So there should be a means, to allow or to open the humanitarian aids, including the health supplies. And I guess in general, conflict should be taken as a public health priority. Quick look, in the last 3 decades, almost 3 million people, 30 million people were lost their lives in relation to armed conflicts. So WHO and others can take public conflict as a public health priority. So thank you very much. Let me acknowledge the brave health workers in Tigray, as well as also the PHM for organizing this webinar, the online gallery, as well as also 2 letters of solidarity and calls for action. Thanks, Hani and David. Professor Frambem, I'm not sure if she is here. She has been bringing Tigray's issue to PHM and other stakeholders' attention. So I really thank for her as well. And thanks, Mr. Altaf, for attending in such a short notice. And I'll show you a quick video later, which was organized by the David Media. So I thank you, the David Media, as well. Thank you very much.
Thank you very much, Dr. Hailay, for the great presentation. Just before we finish with you, there are 2 questions on the Q&A for you. One of them is about the direct impact of the war on the infrastructure. Can you elaborate a little bit about that?
Yep. So like I said, this is just a slide that shows the direct impact. So when I say direct impact of the impact of the war on the health infrastructure, that means health facilities are damaged. That means health facilities are looted. That means health facilities are distracted. Not only in the the infrastructure itself, but like I said, the health workers who are in charge of the health facilities are also part of the attack. So that's to me that when I say direct attack, they just literally some of the health facilities, the hospitals, for instance, Adelaide Referral Hospital was completely changed into a military camp, into the Eritrean camp. The Adelaide pharmaceutical factory was completely looted. Like all the materials for the factory was actually taken by the Eritrean forces. Another hospital in Abiy Adi, it was, well, some part of it was changed into a military camp, and in fact the hospital was only allowed to treat the military forces, the Ethiopian military forces, as well as the Eritrean forces. It wasn't allowed to treat the civilians who are residing in the catchment areas. So that is the meaning of the direct attack of the health infrastructure.
Great, thank you very much. And also the question is talking about the long term, the prediction for long term, and I think this is a good discussion after all the presentations. So just please take note of that and address it later, and also the destruction in rural areas. So we may leave these items for further discussion. Thank you very much, Dr. Hailay, once again. And let's move to our second presenter today, Dr. Maru. He's a principal researcher, research scientist, and active member of the Global Society of Tigrayan Scholars. He's an Australian citizen, but also he has families in Tigray. He will be presenting about the context of the war in Tigray. What do we have the war here now? Dr. Iyes, you hear me?
Can you hear me?
Yes, thank you very much.
Okay, I am just struggling with my internet. I'm traveling and I'm just having troubles to putting my presentation on. So I hope this comes through. Okay, can you see something?
Perfect. If you can make it a full screen, would be great.
Okay, I'll do that. I'll try. So thank you very much for the invitation. I really appreciate you gathering this webinar for people to understand what is going on in Tigray for the last 2 years now. So I am grateful for the invitation. I will try to make a summary of what the core messages are from my side. What we have in Tigray is not a political conflict, although it has been described that way. It's not even a civil war, but a mass crime and a genocide sponsored, enacted by Ethiopian government against its own people in collaboration with a foreign country forces, and also supported by significant amount of armament, lethal armament, directed at the citizens. It's a multi-pronged and multi-round genocide. It involves mass killing. Sorry about that. There is a significant ethnic cleansing that's happening in different parts of Tigray. There has been a siege that has been crippling the state and the entire population. Humanitarian blockade openly, with international community watching, used as a weapon, displacement of significant proportions, internment of many Tigrayans across the country, weaponized starvation, rape, denial, destruction of facilities, that basic services. And it has been rounds of those genocide activities that have been happening, and currently a massive one is underway. It has been 2 years and a couple of days now. There is indescribable catalogue of horrors that could be spoken. It just tires us to even imagine that as humans we are capable of doing those atrocious things. There are numbers, but that can't describe it. I mean, the horrific, for those who've been left, have been taken in a very horrific ways, but even for the living remaining Tigrayans, the horrors are quite significant. So there are reports around an estimate of 600,000 Tigrayans being killed, starved to death, denied access for health, and mass killings. 2.6 million displaced. 2.3 was the figure before, but now there is also new waves of displacement that's happening. Rape is rampant, and now there is new rounds of perfected raping exercise that is happening against underage girls and women. And the list goes on. You can understand the psychological trauma and the intergenerational deprivation this one is going to leave. So I think understanding the scale helps quite a lot, not to call it as a war, even a war, because wars have rules, and this has no rules. And it's a significant devastation of just for all humanity. It is enabled by the indifference in action by international organizations, regional and international organizations. AU endorsed it at the beginning, the commissioner, and United Nations organizations have been indifferent to what is happening. So your voice, your support, your solidarity is essential to Tigrayans, to all of us going through this genocide, because this is directed at humanity. Location: northern Tigray. Tigray is the northernmost part of state of Ethiopia. It's a small state, so we are a minority. Ethnic composition is quite uniform, but we have also minorities within the minority whose existence is now under threat, particularly the Kunama and Europe population, small in number, close to the Eritrea border, have been subjected to extinction. Well, a little bit of history. I mean, we could have gone back for long, but I think just starting even from when Abiy came to power through usurping the movements that youth, particularly Oromo youth, started for greater democracy, for sharing of the outcomes of some of the fast economic development that was happening, that was usurped from within EPRDF, the Ethiopian People's Revolutionary Democratic Front, which was leading the country. PLF and other institutions, political parties were part of, which I must say a lot of people might not understand, Abiy was part of that EPRDF, has been a minister, has been a director of the intelligence office, and all the authorities currently presenting themselves as if they are different, were part of EPRDF for good or for the worst things that might have been done by EPRDF. Then that turned quite significantly quickly and was directed at Tigray People's Liberation Front, but then it didn't stop there. It also directly castigated the entire population of Tigray as enemies. And the war started November 4, 2024, but before that there were lots of signs of this happening, and there was warnings from Crisis Group and others coming that this could happen, because there was hate speech that has been even by Prime Minister himself. A lot of people have been displaced. Close to 100,000 Tigrayans have been displaced, and their everything been taken away from them, and major road to Tigray was blocked starting early 2018. So the writing was on the wall that this was coming, but no international regional organizations have acted on time. And what was taught, it was a peace process that started even before Abiy came to power, was turned into a war pact, which ended up resulting in this significant genocide. I think what could be summarized is that the Ethiopian Prime Minister wanted, in fact, in an inauguration, he spoke that he would like to be, he was prophesied by his mom that he would be a king. And so there was an interest to be a powerful man that drove those. Eritrean president has said game over, and that he would change. He would completely wipe out Ethiopian political process, and Amhara state governments have been speaking out. Even the former president of the state have spoken against Ethiopian Tigrayans as people who are enemies of all other peoples in Ethiopia, and that was also openly spoken to the EU envoy, His Excellency Pekka Haavisto, Finland's foreign minister, that the Ethiopian leadership were openly saying that they will wipe out the Tigrayans for the next 100 years. I think the multi-pronged nature of the genocide is witnessed across starvations, human-made starvation that killed hundreds of thousands of people. Bombardments that are ongoing, has been starting quite a long time ago and then still ongoing. Even use of prohibited chemical materials that burnt a lot of people and destroyed villages, and also mass killing, openly shooting young people who've been captured from their settlements, and a rape that was rampant. And some of the pictures that you could see, and also horrific things that have been done on people who was found floating in Sudan shores. And it's also a significant number of people, including the former Tigrayan members of the Ethiopian National Defense Forces, are still incarcerated. Some of them have died since, because of a tremendous, atrocious treatment and torture. I mean, has been a lot of international organizations have said a lot about what has happened, and it has happened last year in 2021, and now it is coming with full swing, trying to finish off what was started previously. And famine was recognized quite a long time ago, but the UN doesn't have even the guts to declare that, and supply supply what is required for people who are suffering too much. Okay, I will go on. As now a new round of war, you might have seen it. There's an entire Eritrean army has joined. In fact, there is a joint operations that is currently happening. Seems that it's been led by the Eritrean military forces, where the Ethiopian forces have gone to Eritrea and launched all those attacks with Eritrean forces, and now Tigray, Western Tigray is occupied. A lot of major cities have been occupied, and also in southern Tigray, Lamata and Koram, so southern part and southwestern part of Tigray is also occupied, and hemming this poor people who've been suffering for almost 2 years with blockade and siege, now have been displaced significantly and deliberately into concentration camps and attacked severely wherever those forces set foot. There's a sort of burning of settlements. There is a significant rape that's happening, and mass shooting of young people and elders, horrific ways. So it is now getting perfected. What was missed last time is now getting perfected, and if there is no intervention, there's a lot of talk about there's no military solution to a political conflict. But this is not a political conflict, this is crime, and a crime requires intervention. Otherwise, the people of Tigray are condemned to be eradicated. That's what's currently happening. So in a sense, I might just summarize here what we require of those who are attending today is really to understand the degree of significant problems. The international community is slow and sometimes also indifferent, given the right attention that's given to Ukraine. The humanitarian toll in Tigray is significant. 100-fold have died than what was reported in Ukraine. And that was an estimate, was what could be found from evidence, but could be even more. And the extent of atrocities that have been committed, coordinated atrocities with no rules have been committed, is no comparison, but the attention that's given is quite slow. In the peace process that is happening we are always hoping that the peace would come, but we also know that the trickery, the deceit, the Ethiopian government is engaged in, and any day that's passed, any hour, any minute that passes has a cost, material cost in the ground in Tigray. Lives have been lost every minute. The longer this peace process goes, this impact would be devastating, and Tigrayans don't have an option but for peace to come through or fight and die. But the Ethiopian government could stop this whole process now, and negotiations could start for a just peace and justice that needs to happen. So what we ask from all of you is that, one, you become advocates of this human tragedy in the 21st century. You support and technically, materially to the health services in Tigray, and particularly there are also people who've managed to flee to Sudan who are suffering quite a lot, and there is a lot of support that could be provided there, and also call for cessation of hostilities and for genuine peace process to happen, but separate the humanitarian aspect from any peace process, and ask for a direct and immediate intervention. Humanitarian crisis should not be tied up with a peace process, shouldn't have to be waiting for the peace process to come, because by then people Tigrayans would be lost. Many thousands of Tigrayans would be lost. So for separation of that to happen and for a direct intervention, so all the forces who are now hostile to the people of Tigray has to leave, so that to the pre-war status in all places, so that a peaceful process and a negotiated process could be in place, and a just foundation could be found for a reconciliation, a long-term reconciliation that needs to happen in Tigray and Ethiopia. Thank you very much.
Thank you very much, Dr. Mauro. And I see some comments and questions. They are quite not directly for the presentation, but they are for very good discussion after all presentations. Let's, for the sake of time, let's move directly to Dr. Fasika Amdeslasi. He's a surgeon from Tigray. He works for either referral hospital in Mekelle, which is the biggest hospital in Tigray, and he's based in Mekelle. As a physician, and he's facing the daily suffer of patients and healthcare workers, and he's going to share with us selected stories from patients and healthcare workers. Fasika, the floor is yours.
Okay, thank you, Hani. It feels like I am seeing all these colleagues at once. It seems I am coming back from Mars or some of the outer spaces, because we have never connected with this number of people for the last now 17 months. So it's a pleasure to be present amongst you. I will share my screen and start the presentation. So I will be telling you stories about our patients and about Hailay. They are not great stories, but please keep up with me. So this is our Hailay. It's one of the biggest hospitals. It's the only biggest hospital in Tigray, serving 8 million people. So the background, however, been discussed. We have no meds, no food, no phone, no internet, no fuel, no bank, no cash, no salary for 17 months. So I will start by telling you stories. So I will start with Mr. Ashanafi. Mr. Ashanafi is a 35 years old male. He did not have work because of his illness. He was married and has 2 kids. One is 7, the other is 5. They live with their grandmother in Intijo. His wife is in Saudi Arabia. Then he had to sell his 250 square meter land in Intijo in 2019 to help raise his kids and for his dialysis. And then, so the background is he was diagnosed with hypertension 4 years back. And then before the kidney diagnosis of the kidney failure. So he did not take treatment, so he developed chronic kidney failure. And in 2018, the kidney failure was diagnosed, and he was taking hemodialysis 3 years. For 3 years, 2 times in a week. And his health status had improved remarkably. He used to have psychological stresses, as he was unable to work and he cannot raise his kids, be with them in Tijo. So he had to rent a house in Mekelle for 3 years because Mekelle, the only dialysis service is in Hailay in Mekelle. So Tijo is 148 kilometers away from Mekelle. So he had to be separated from his kids. So that put him in psychological stress. This was his personal testimony. Then war happened. Then the consumables for dialysis, they start to dwindle. And then for months, Up to 6 months, they were not coming. And so he started to develop symptoms of suboptimal hemodialysis, which includes nausea, vomiting, feeling weak, and accumulation of fluid in his belly and lower legs. Then, because our nephrologists in the dialysis center, they were using single-use dialyzers multiple times, 6 to 8 times. So the symptoms don't improve. It has never been done, practiced elsewhere in the world. These are single-use dialyzers that you use and discard. But the helpless nephrologists, they had to use, they had to improvise. So basically, it did not, patients did not die, but they did not have significant improvement. So progressively, he was critically ill with fluid accumulation in his lungs. He became hypoxic. Finally, he was admitted to the emergency department, where he was kept overnight in case the supplies arrive. But Ashanafi, the next day, he said to the emergency care team, "I have to go home. I am becoming a burden, and there is no service, and it's not so helpful. So I don't want to be a burden to you. I just have to go home," he told them. So he has spent a year fighting death because of the supply not coming. It was a year fighting death, and with these symptoms. So it was so frustrating for him and for his treating physicians. So he died on his way home anyways. And the whole team, the dialysis team, Dr. Ephraim, Dr. Mekelle, they were devastated by his untimely death. Few days later, ICRC brought the dialysis material after Ashanafi has left. So this is one of the stories. So in this, since last June 2021, 17 months back, there were 90 people who were on dialysis, chronic kidney failure patients. So 65 have died like this. They have individual stories, and only 25 remain. And yesterday, I went to the dialysis center, and the last material was being used. And today, and starting from today, there will not be dialysis materials, and all of them will die in the coming days, unless the materials come as soon as possible. So this is Ashanafi taking his dialysis before his death. The other is Solomon Wallai. He is a 16-year-old male. He's from Mekelle. He came with a complaint of excessive drinking, polydipsia, and then excessive urination, polyuria, and he had significant weight loss. These symptoms, they lasted for 3 months. Since his father was not around, so he's the only one to provide for his family, his mother and his 2 siblings. He works as taxi assistant, so he kept working, survived despite all symptoms, but eventually he became bedridden. Since 1 week, prior to 1 week before his admission, he started to have abdominal pain, vomiting, and change in mentation. So when you stop taking insulin, in insulin-dependent diabetes mellitus, in type 1 diabetes mellitus, you develop a fatal complication called diabetic ketoacidosis. So upon arrival, he was comatose, dehydrated, and he was malnourished. So he was diagnosed with moderate diabetic ketoacidosis. Despite all his complaints for 3 months, he could not. He lives in the Mekelle, so he could not go and get treatment because there is no medication in the health facilities, health centers. And so his family had to take him to the holy water, but he deteriorated for the last 3 months, and he came after he has collapsed. He came to the hospital. So in our hospital, we couldn't do necessary investigations like electrolytes. The laboratory is not functional for 17 months. Almost all supplies, they were not resupplied. for the last 17 months. So you cannot manage DKA without electrolytes, and you cannot manage DKA without insulin. So he needs fluid, which is normal saline, to manage his complication. Fluid management is one of the managements, but that's not even available. And the patient cannot afford to buy outside, because outside the hospital, there are private pharmacies who bring smuggled medicine for very expensive prices. It is 700 birr, Ethiopian birr. It used to be 30 birr or 40 birr. You can imagine. So this guy cannot afford. And insulin also is not available for now almost 2 months, since August. So there is no insulin. We cannot get him out of this complication. So he is in our hospital right now, and he's awaiting his days. His mother cannot afford, so he awaits his days. Now I would go to, so there are like thousands of stories like this in IDER. I just selected 2, but there are stories like mothers who had to be carried for days, who had to travel for days from rural Tigray to arrive in Mekelle, and those who did not make it die in their home, closed behind doors because there is no ambulance, there is no transport, there is no nearby health facilities are not working. So I just had to select 2 cases for you, because for time constraints, because times we can go on talking about a lot of cases, and I'll come back to our staffs. So this is the first is I have selected is she's a nurse, and she's 30 plus something years old. She's a mother of 3. She used to have a good life. In addition to working in the hospital, she had a 3-wheeler, a bakery, and her husband also used to be government employee. Now both of them are they don't have salary. So to feed her family, she wanted to sell her Bajaj, but they they promised to give her only 10,000 for a 207,000 per vehicle. The Bajaj is a 3-wheeler, and so they give her 10,000, and 50,000 is by bank account, and she will not get it. So that's basically she has to throw it away. And she has 300,000 birr in her account. To transfer and receive cash, they asked about 57%. So they will, if she gives them 100,000 from her account, they will give her 43,000 for her, and they will take 57,000 for themselves. So this is again very unfair. She has been listed for aid by diaspora and the hospital. Diaspora Tagaru, they used to send money. So on and off, there are some small amount of money, like 1,000 birr and the like. So her family they skipped meals. They went hungry multiple times. So to feed, she has sold her gold multiple times to buy food. She used to have a good life, and the gold she's selling it for 50% of its price, but she still is hungry with her family, and she's still coming and working. The other is sister wise, and her husband also a government employee. She delivered her second child in June 2021, right before the siege, and then she developed deep venous thrombosis. She was on wheelchair for months, unable to move. Since IDER was not functional, she had to go to private hospital by transferring from her account to the hospital after so much begging. Now she's still taking warfarin until now. She had sold her golds, even some household equipments, to buy warfarin. She has to buy, because warfarin she's taking it now for 17 months until now. So to buy warfarin from the contraband pharmacies, she had to sell her golds. She has lost weight significantly. Her kids have lost weight. She comes and cries every day while at work in the hospital. The other is another nurse, 40 plus, mother of 4 kids. Her oldest one is 17 years old. Her husband is a trader, and he's locked in Addis. He went to Addis last June, and then he stayed there. And her husband's father, who lives in Mekelle, is very sick. She had to take care of him, and she has gone hungry multiple times because no salary, and with her whole family, with her children. And she had to take care of her father's father, her husband's father. So because she cannot afford to come and go, she moved with her kids to her husband's father's house. But she cannot have him treated because there is no money and they don't have money. And it's painful to see her children and the old man hungry. So she cries. It's her when you talk to her, she cries helplessly. The other is a porter in the hospital. She's 30 years old, mother of 2. And then there was a time this woman disappeared from Eider for 2 weeks. And even a notice was going to be posted. Where are you? Please come and report. And but then one day she came to the emergency department, collapsed because she did not eat for 3 days. She was hypoglycemic. So she was giving whatever is available to her children. And she had to go to collapse, and then she had to be brought to the hospital. So like this, we have thousands of case stories. We hear it every day. There was a day when in the hospital, somebody was having a snack and he offered to the sister, please, let's share. And she cried. I did not give my children breakfast. How can I eat without them? I don't want to eat. She said that. So you see such kinds of tragic stories again and again. Now we are almost planted. So I'll give you some pictures. There were ICRC has given us wheat floors. So these are our sisters nurses taking the 15 kg wheat floor 3 or 4 times in 17 months we have been given. Another time when everybody is sharing. So this is in the hospital compound where we were taking food to our children. So this has been the trend. We are very happy when it comes because at least then we're going to have bread in our house. So this is the queue waiting for, and this is the right side corner is Dr. Abraham. He's a pediatrics neurologist, and he's currently the vice medical director of the hospital. You can see. I took the picture myself. You can see him after he has received his wheat flour, after sharing with his with his colleagues. So surgery. We have boiled salt in saline to replace saline because to wash wound, to wash abdomen. We are not even sure whether it's medieval surgery. We have collected clothes and dress, so-called gabi. It's a traditional cotton from churches, from people. Then we cut it and we sterilize it to use it as gauze. We have used expired anesthesia drugs where patients awaken in the middle of surgery, or they don't wake up at all, or things like that. We have ventilation machine discontinued when oxygen ran off. So you had patients on machine, then we discontinue when oxygen ran off. And there were times, always there is no IV fluid for patients with trauma, with post-operative, and then we see them die. As I have told you, one IV fluid costs 700 Ethiopian birr outside. And it used to be probably 30 Ethiopian birr. So there is no antibiotics. We have not used antibiotics almost for 17 months. It's erratic. Whatever is available, we try to give. So we see pus abscesses, infected wounds, repeated surgeries, prolonged hospital stay, deaths. So we're back to 15th century surgery. And that now even we have stopped now for 2 months, including cancer surgery. So healthcare workers, we feel useless. We are stressed at home because at home our kids are hungry. They don't go to school now for almost 3 years. And we are stressed at work. We are stressed by our environment. There were shellings, bombings. It's like an open air prison. We are stressed about the future, hopelessness. When will it stop? And we know the disease, but we cannot do anything about it. So we are doomsayer. We are bad storytellers to the patients. You have this, but alas, we cannot do anything about it. So that's our story. Thank you for listening.
Thank you very much, This was a very strong presentation, and there is one direct question to you about, if you can see it here, the last one about the situation in Tishu. I hope I pronounced right. I think it's a part of
what was that?
Tigray.
Inticho,
Yes.
yes.
If you can, just in a minute, if you can respond to this question about what is the situation today. Last year, there was troops from Eritrea topped into the place. Can you discuss that briefly, please?
No, it is difficult to know. Widespread lootings have happened in Tigray. The lootings are systematic, and it's not only looting, but it is vandalizing. So I don't remember anything specific about Inticho in the last years. And currently, there is no way to know about it because there is no connection. Nobody goes to those places. I have not met people. But in Tigray, there were widespread systematic lootings and destruction of food, looting of food, destruction of materials, looting of materials. That is one of the reasons that makes our society vulnerable to hunger for the last 17 months. So that's all I can say.
Thank you very much. Let's move to the video. Hailay, if you can start presenting and share the voice before we go to Dr. Altaf.
Can you hear it?
Yes. No, share the voice, please.
Pardon?
Share the video voice, the sound.
Ladies and gentlemen, you're about to see a very short video of the horrendous situation in Tigray, the Tigray genocide. This video was prepared to give you some clues about the deliberate destruction of health systems in Tigray. But this is just a drop of water in the ocean. But the overall destruction is way beyond one's imagination.
I'm Ebenezer Zadinga. I'm from the Regional Health Bureau, Emergency Medical Services. I have been coordinating the emergency medical services in the region for the last 3 years. And I'm a doctor by profession. As we all know, the last 2 years were the worst time in our lives. I don't think that I will ever see such quagmire, such inferno in my lifetime. The health system in Tigray has been deteriorating for the last 2 years, as we all know. Even though it was the best in the region in a sense, in the whole of Africa, that I can say, in many parameters. But unfortunately, due to the conflict and the war, the health system has almost, we can say, collapsed.
And I was in Shire, which is in central Tigray, and also in the surrounding, in some of the villages, and I saw firsthand myself the destruction and the looting of the health facilities. But overall, we saw health posts, health centers, and hospitals being damaged, looted, vandalized over the past 4 months. We have seen over 106 facilities in this period. And to describe the vandalization a little bit, you have to imagine that you're walking into a room that is 3 by 4 meter, full of shelves until the ceiling, you know, where normally all the drugs are stored, the medical supply is stored, and all the jars, you know, where the drugs are inside, they are opened, and all the pills are thrown on the floor, all the vials are thrown on the floor, the cold chain for the vaccination for the newborn is destroyed, patient files are thrown around, laboratory equipment is intentionally destroyed so you can't use it anymore. And you go from room to room where you see this destruction and this you know, malicious vandalism, I would call it.
Before I joined the Regional Health Bureau, I used to work at the Fatsli Primary Hospital. The hospital was a primary hospital, and it was the best primary hospital because a lot of investment has been done by the people and by the government as well as by the private donors. And as a young and enthusiastic medical doctor who has been a medical director to that hospital, and the hospital was completely looted, destroyed.
These attacks are happening while we have no medical equipment left in hand. We are here to serve our community. But currently we're running out of glove, anesthetics, or any other necessary materials. It is terribly hard for us.
We are in an active conflict area, as we all know, so we have to respond to shellings, to airstrikes, and also to the basic services of emergencies, such as the pre-hospital services, such as bringing a laboring mother to hospital, or bringing someone injured to hospital, and also just providing the basic emergency supplies like blood and oxygen. And to give such services, it's really it's beyond to comprehension to express the challenge that we have. There's no fuel to run ambulances. There is no way to communicate to the victims. There is no way that someone who is injured to call ambulance and get the service. There is no way. Even though we have some teams to respond to such, for example, if there is an airstrike, we have a team that we have somehow scrambled to respond, and there's no communication. So the only thing they do is they watch for any smokes or for someone just to inform them that is someone injured somewhere. The greatest difficulty is to have the supplies. There is no medication. Even though we have somehow managed to bring some patients to hospital, there's nothing we can do at the hospitals. Significant of them, as we all know, are depleted of their supplies. For the last 2 years, we have been using our reserves, which are not that much. And even though there were some medications that were able to trickle to Tigray, but still they are significantly low, and they don't include all medications that are needed.
Due to the siege-induced lack of medical equipments such as antibiotic, gloves, pain relievers, we have nothing to help the victims with. It's so sad.
There is no other situation globally in which 6 million people have been kept under siege for almost 2 years. Banking, fuel, food, electricity, and healthcare are being used as weapons of war. Even people who have money are starving because they can't access their bank for 2 years. Children are dying every day from malnutrition. There are no services for tuberculosis, HIV, diabetes, hypertension, and more. Those diseases which are treatable elsewhere are now a death sentence in Tigray.
እንደገና ህዝብ ድጋሜ ተመልሶ መጥተው ጨረር የድለክ የተባለ በሚታከለ ተሰባ አይከፈለ ካርት መድኃኒቱ ከግኔ ካርት ስለዚህ ናተሳቀናና ነና ለዓለም ፍሬና ከማያታቶ እንደላ ዘርቁ ከአርፍተ በልከስ እንተም በመሉ
Thank you very much, Hailay, and thanks for everybody who worked on this video. Let's move to Dr. Altaf Musani. Thank you very much, Dr. Musani, for joining us. Dr. Altaf Musani is currently the Director of Emergency Health Interventions at headquarters of World Health Organization, and his responsibility is to streamlining the WHO operation in fragile, conflict, and vulnerable settings, with a special focus on the management of high-impact disease and coordination of global health cluster partnership. He served in many places with conflicts, especially in the Middle East. He served in Iraq, Yemen, Djibouti, and many Jordan and other places. Thank you very much for joining us today.
Thank you so much, Dr. Henning. Can I ask if you can see the screen clearly?
Yes, very well. Thank you.
Wonderful. So my apologies. I know that we were piecing this together last minute. First of all, thank you very much for the organizers for inviting to participate. And I know that you wanted some feedback on some of the first presentations. Let me start by echoing what is mentioned in the chats, that it is very difficult to present after our presenters shared so many of the horrific stories, particularly of patients and healthcare workers. And I think it is vital that we continue to bear witness to what is happening. So my heart and all our support goes out to all those healthcare workers who are struggling. I think for me, that is point number two. All of us remember the days of the pandemic and how our healthcare workforce was really stretched to the brink with lack of supplies, without diagnostic materials, without treatment materials, and without the knowledge of dealing with one virus. You can take that and then amplify what our healthcare workforce is dealing with in Tigray, and it's tenfold, if not 100-fold. And so again, a deep acknowledgement and a sense of honor and awe for all those healthcare workers who continue to work in these extreme hardship places. They're dedicated. The speakers clearly said they work without supplies, without electricity, without money, put their own lives on the line. And I think we should acknowledge as a community at large the work that they do. Two other quick points before I get into my presentation. Additionally, I'd really like to acknowledge the speakers who mentioned the burden of chronic illnesses. Too often in the emergency settings that we work in and we witness, there's a heavy emphasis either on trauma care or the control of infectious diseases. And it's really important that two speakers did point out, whether it's dialysis or whether it's access to cardiovascular medications, that burden is a true burden. And often our donors and partners don't understand the complexity of that interface between the people, the providers, and the system. And I think the system is vital to make sure that it can provide healthcare when you can come to the doorsteps of a hospital and healthcare center. My last point is obviously when we talk about the system, and I think, again, the speakers reinforce this, we're not only talking about physical damage or destruction to the system. A system goes non-functional when there is no electricity, when there is no water in the facility, and most importantly, when the workforce or the medicines and the technologies required to diagnose patients is non-existent or been damaged. And so when we look as the World Health Organization about the functionality of the system, in Tigray, it's only 9% that is fully functional out of roughly 232 facilities, and 90% partially functional. So you can imagine, even when we do have access, our system cannot cope because of the reasons I mentioned. So with that said, I'll just briefly walk you through. Now, my presentation is just focusing on a narrow window of what we see as public health risk. I won't do justice to what my colleagues have already done. And again, I'm hoping that the presentation complements what they've already cited in terms of data, what they've cited in terms of trends, and in terms of needs. And we're hoping that, I think a lot of questions are asking what more can be done and how do we position healthcare to remain neutral, to remain impartial, and most importantly, to be accessible. So with that, let me start by just painting a picture. I think, Hani, you said very clearly, when I look at the world with my colleagues, it's unfortunate and it's deeply saddening, horrific. It's unacceptable that we see what we see in Tigray, but it's unfortunate we see this also in other parts of the world. The pain, the suffering, the lack of access, this has now become a common feature in fragile conflict and vulnerable environments. And the United Nations estimates that there are more than 300 million people who are in urgent need of assistance. And you can see very clearly that need exponentially grows over time. And that this is not just because of COVID. This is because of climactic stress, change in conflict lines, change in vulnerability, change in funding partners. And so there's a whole range of reasons why we find ourselves having to deal with more rather than less. Of course, there is a price tag for this, and we appeal to all our donor countries to be able to provide that funding. Here, the slide very clearly shows 41 million, but as of the last 72 hours, that figure has increased to more than 50 million. So again, we are thankful to our donor partners, and we ask them that more is needed to be able to really safeguard lives and systems. In addition to that fragility and vulnerability that I described, our own institution, working very closely with healthcare workers and partners, has an additional 52 acute events. And you can see on the left-hand side of the screen, this is everything from monkeypox. COVID-19 did not go away. This is the new outbreak in Uganda of Ebola virus. This is the 29 to 30 countries that are experiencing cholera and yellow fever. So I say that just to, again, really emphasize the importance of the vulnerability we're dealing with. Now, specifically on Ethiopia, again, my colleagues have done really good justice in terms of trends, data, and needs, but just to try and repackage it together. When we look at the country at large, more than 29 million people need assistance. That is the benchmark, the kind of the entry point for healthcare workforce and ourselves as partners to be able to say, how do we position supplies? How do we address the multiplicity of healthcare needs for more than 29 million people, particularly in Tigray? We're looking at 13 million people. And again, we're very clear to put numbers, but I really want to give profound thanks to my colleagues who humanize those numbers. Behind every number, there is a child, there is a mother, there is a grandfather, and it's really important that we remember that. We use these numbers interchangeably to be able to advocate the severity, the scope, and the scale of the problem. But you see there very clearly what we're dealing with in Ethiopia. Now, as an institution, we have certain tools and instruments how we define public health risk. And you can see here, I've taken a very clear snapshot that was developed mid-2020 for us to be able to define what we see as health risk in Tigray. Very briefly, and we don't have the time to go through that risk, but just to let you know, we cited very clearly on in this conflict that acute malnutrition, rise in malaria, the risk of cholera, and now what we're seeing in terms of measles are genuine humanitarian public health risks that we must focus our energy on. Of course, those are not the only ones. As cited earlier by my speakers, the burden of chronic illnesses, as well as trauma and injury, equally are important. But then when you have a large menu of options, the solution is to make sure that the system is responsive so it can deal with a range of health conditions. We were very quick to then define what that means in terms of quantifying that risk. And so whether it's acute malnutrition, meningitis, yellow fever, we looked at the population at risk, used attack rates, came up with caseloads, and then even severity. So we're very clear in terms of what we're dealing with. Now, the challenge going forward, I think, as my colleague said, is when those information systems, particularly like surveillance, go offline. We are highly dependent on health facilities, healthcare workers reporting what they see. Now, that's done in a standard form and fashion. There's a lot of training, whether it's early warning outbreaks or whether it's surveillance systems. We invest heavily in that. Now, positively, the world has come closer to reporting more, but our systems are very unconnected, very fragmented. And obviously the case in point in the north, they go offline for quite a period of time. And therefore, during those data gaps and those data blackouts, we're deeply worried, as the screen shows, a rise in malaria cases, rise in typhoid cases, the rise in dysentery, and the rise in malnutrition. So it's very important at the cornerstone, while we're safeguarding the system, we continue to report what we see so that way we can then pre-position either the intervention, for example, if it's a cholera outbreak, how do we get oral cholera vaccinations in place? How do we set up diarrheal treatment centers? How do we break down delayed onset care and then complement that with wash and sanitation strategies? So this is just a snapshot of our ability to monitor the disease outbreaks as well as information coming in. You can see here, we don't only focus on Tigray. We know, and we've said this very clearly, our Director General has said this about the pandemic, the diseases don't respect the borders. They will find vulnerability and they will find their way. Now, in the past, we know that health-seeking behavior in the north was very interchangeable. The borders were thin and that were referral hospitals on all different sides that health-seeking behavior was happening. But we do look at what is coming into the system when functional. And here again, whether you look at Amhara, whether you look at Afar or Tigray itself, you're starting to see large proportion of mortality, particularly among children. Now, again, I want to caveat to say that this is where systems work. So it's really a snapshot. We anticipate it being much worse than what is being reported here for the purpose of data capture. Another important point that was stressed by a lot of our speakers was the issue of malnutrition. Here again, using the standard rates of either global acute malnutrition, moderate acute malnutrition, and what we're equally and deeply concerned about is severe acute malnutrition, particularly the SAM cases and the SAM cases that have medical complications. Those need the system. Those depend on the system for survival. So those children need to be admitted. And we look at admission rates, we look at recourse rates in terms of readmission, we look at survival rates, discharge rates. And again, the picture is grim. And so we have been advocating not only the increase in terms of food security, but making sure that this goes hand in hand with other interventions. And it was clearly outlined. You need fuel, you need food, you need banking, you need telecommunications, all hand in hand to be able to address the challenge of malnutrition as well as infectious diseases. Going forward, here again, we are starting to enable the system to look at some level of precision and trends. We're able to see what happened in 2020, 2021, and 22, see the rise in those cases, have some level of comparability, and not for the purpose of comparing suffering to suffering, but really to say, where do we see peaks? Where do we see lows? What's reported, what's not reported, and where people are seeking behavior. This helps us establish whether there's a therapeutic feeding center established or there is admission cases in a hospital for those medically complicated with severe acute malnutrition. It's really vital. And again, this helps us really understand the severity of the problem, but also provide treatment as and when supplies are needed, available. And I think a number of your colleagues very clearly said, supplies are not there. We know that saline is not available in Tigray. We know antibiotics is not available in Tigray. We know medical consumables are not available. And this just further complicates and challenges our ability to really drive down mortality. I wanted to end with the fact that we start to see vulnerability stretch across the board. And as I alluded to earlier in the first slide, within the 52 events that we're struggling with is a major drought. And this is in the greater Horn of Africa. This is obviously spilling into Ethiopia and further exacerbating the problem as healthcare workers to try not only provide aid in the north, but also aid in the south. And why it's important, we're starting to see cholera. Cholera is endemic in Ethiopia. Many of the colleagues know this, but we have now confirmed cases as well as outbreaks in Oromia and the Somali regions. The data speaks for itself. And equally alarming, and I think one of the colleagues alluded to this, was the immunization coverage. That low immunization coverage opens up the vulnerability for children to have measles. And you can clearly see we've got more than 5,000 cases that are nationally reported. That's what's hitting the system. And this is stuff that is achievable. Vaccine preventable diseases is covered through vaccination programs. It's important to be able to get jabs in the arms of children. But when they're malnourished, when they're already immunocompromised, it makes it even more complicated, and you further propagate the vicious cycle of mortality. I wanted to end there. Again, it was just a quick snapshot of what we see in terms of health information, the severity of the problem. We have more than 56 metric tons of medical supplies sitting in Addis. We have an additional 20 plus that are malaria dedicated. We know our partners who have access or don't have access are pre-positioning supplies. And the the key issue for all humanitarian partners right now is the access into Tigray, and making sure that once that sustained access is available, those supplies, the fuel, the funding can come in to really make sure that the systems can get propped up to serve the people most in need. So thank you very much, Hani, and back to you.
Thank you very much, Mr. Altaf. There is one direct question to you. It's about the WHO surveillance system for attacks on healthcare. It said that the database reports no attacks in Tigray. However, there is evidence that the database works because it reports attacks in Ukraine. So can you please clarify that?
Absolutely. And I think it's a very important question. When you look at the attacks on healthcare, it is subject to and dependent on partners and people entering the data. WHO does have a workforce on the ground. It's not present necessarily in every facility, but that system called the SSA is dependent on partners and people entering data. Now, the second part of that, which is vital for us as an institution, is our ability as the World Health Organization to verify the fact that those attacks have occurred. And bear in mind, the definition is very broad. We're not just talking about physical destruction. We're talking about denial of health facilities or the use of health facilities in an inappropriate manner. We're very clear on the denunciation of that. We need our partners and healthcare workers that feed that system. Once they feed the system, we're enabled to do a verification of means. Now, we've been struggling with this. As you said, there's very little to no data in the system. We have dispatched our experts down to help train partners, but there has to be that will and that appetite. Now, there are concerns around safety and access and security that partners have often cited, but here again, it's important not only to bear witness to what's happening to the system, but make sure that as and when the system is rendered inoperable or non-functional, we as partners try our best to help bring in supplies or prop up that system for all the different disease conditions that I described to you. So it's really, really important. Obviously, other countries are very active in providing that data. They provide that data quite regularly. And then, of course, we have that means to provide the verification of that data. So again, a real important call to partners to help us feed the system.
Thank you very much. This is clear. I will try. I hope I will make just to summarize the questions we received, but also I would like to take permission from everybody to extend the webinar a little bit to have some discussions. I know we reached the limit of time, but I hope everybody agrees we give at least 15 minutes more to have some discussions. So if I want to categorize the questions we received, they were about the humanitarian aid, the separation between the peace process and humanitarian aid. Also, there are lots of questions about the role of international community, and this includes international organizations, the enforcement of international treaties, and also the role of civil society and professional organizations. And this would include what PHM can do. And this is a very important question. We would like to hear from everybody about that. Also would like to say that it might need another webinar or discussion about the geopolitical situation in the whole region, because I see this war is not isolated from what's going on in the East Africa in many ways, and the support or silence from big powers. And would say that really the history is telling us that big powers do not mind governments killing their people. And this is not unique for Ethiopia. It happens everywhere in the Middle East right now, as long as these governments are aligned with the imperialism agenda. And the very good example of that is Saudi Arabia. So whatever going on in Yemen, there is a complete silence about that, and everybody's dealing with Saudi Arabia as if nothing happening. And this is the same in Ethiopia. The government has a very good relation with everybody, and the international community is silent about that. So the US, for example, is one of the biggest donors for humanitarian aid, but meanwhile, it's the biggest seller of weapons. So they sell the weapons to governments, and then they provide some aids to those who are victims, and they make business out of both ways. So to which extent we can really rely on the intervention of big powers in terms of governments of imperialistic North, or people power? What should we do? And I will open the questions for our panelists. Yeah, Dr. Maru, can you start?
Okay, thank you very much. So the few questions that might seem to be directed to some of the points that I made. The need for separating humanitarian and medical aid from any process is exercised in many other countries. You don't wait for a peace process while you have almost 7 million people under siege, under famine, locked, and dying. So if you do that, really you're just hastening exactly what those powers who want those people to die are wanting. Any delay, time becomes a very critical input into this equation. So that there are international norms to enact, for instance, for when food is weaponized, and this has been also witnessed by the International Commission for Human Rights experts for Ethiopia, who've attested that there is a reasonable ground the Ethiopian government is using aid as a weapon. So there are grounds that international community to act directly shouldn't have to be dependent or appease the Ethiopian government to allow. They could directly, costly, obviously, but directly reach out to people. Still, there is the Ethiopian government has ignored this one. Is not going to allow for this to enter. So that separation has to come from professional organizations like PHN and other health organizations have to speak out that there has to be a separate treatment for people who are perishing every day, for them to be reached out by. WHO has been vocal about what is happening, and there are individuals who have been vocal what's happening, even in nations. In the US, there are very vocal senators and others who are crying out that there's no point in waiting for this genocide to wipe out people and then say, well, we could have done better, or could have done never again becomes yet again, and that has to stop. So I think there is a need for us to start a new movement, not just only Tigrayans, not only very few active people are speaking, but internationally. This is against us. It has happened in Yemen. It continues to happen. If we don't stop it, it will continue to recur. And dictators like Isaias and Abiy are having a field day because they know the international community is not going to respond. So if we don't speak out now, it's a loss to humanity. Obviously, for us, it's devastating loss. We're just experiencing it. So that's my response to that separation, which we have been calling that shouldn't have to be contingent on any other peace process or ceasefire. There has to be a direct way to help people.
Thank you very much. Before moving to other speakers, Mr. Altaf, there is a direct question as well about the refugee crisis. Those who fled to Sudan refugee camps. What WHO is planning to do for that?
So a very good question. Traditionally and normally, when someone flees forcibly a setting, the agency that steps up the line responses, obviously the United Nations High Commission for Refugees, they're the ones who make sure that the platform for receiving refugees and ensuring that the basic social services are there. We work closely with them through the Ministry of Health in Sudan to make sure that health care, and as I showed you in the case of Tigray, how we define health needs is front and center. We are aware that refugees have some access to healthcare, but probably not the full access to comprehensive healthcare. Referrals in and out of camps become really important for what my colleague cited in terms of chronic illnesses. You know, this again is, I have to say, where the health system becomes primal, right? Because a health post or a primary healthcare center may or may not have the capability to deal with the sophistication of cardiovascular disease or dialysis, and therefore an individual must be referred out. So we're certainly looking through all those issues and work through very closely the Ministry of Health of Sudan. It's important to put in perspective that the needs continue to outstretch, and I reinforce this. Healthcare workers are the heroes and heroines of this world. They're having to firefight, whether it's monkeypox, COVID-19, yellow fever outbreaks, cholera outbreaks, and this is happening on the borders. This is happening as people flee, and we know that refugees coming across the border do have those needs, and will continue to press through UNHCR and the Ministry of Health of Sudan to make sure that those needs are equitable and accessible. Thanks.
And Mr. Altaf, do you think
I would
that
like
the
to
climate?
Yeah. I would like to add, since we are talking solutions, with this Tigray case, this situation, this scenario, it has shown how at times important WFP, WHO, UN, or other organizations can be. This importance, I don't think WHO or UN can continue like this. We are a living witness. We have doctors, we have patients, civilians, non-combatants who are closed off the world for 17 months. ICRC, WHO, or the other, they are supposed to respect human rights, non-combatants, civilians, who does not have arms in their hands, and they are dying, they are perishing. So WHO or UN or the other international organizations has to revise their protocol. Everybody is noticing. Every government is noticing. They don't want to continue as some important organization where they cannot make sure human beings are, when human beings can survive in dire situations. So this importance needs a major revision. When governments fail, when war spirals out of hand, how can we save people? How can we save children? This protocol, business as usual, won't get us anywhere. This is a huge failure in these organizations, and they need to revise. That's one thing I see. Thank you.
Thank you very much.
Just a point and ask a quick question to Altaf as well. Yep. So there are a couple of questions, but I will answer to Eden's question with regards to the long impact of the conflict. I guess so. There is actually a team called JSDS Health Damage and Loss Assessment Team trying to quantify the impact, as well as also predict and quantify, a number of health outcomes. So I can't exactly answer, but what I can say now is I think Tigray will definitely live with a number of mentally retarded children resulted from the lack of vaccination. Tigray definitely will struggle with a woman who will be living with a chronic mental illness. And there will be a number of women who will raise the children that were actually conceived from their enemy, from their perpetrators. And that needs a kind of a long-term thinking. And definitely there will be a number of disabled people, civilians, as well as also combatants. And the chronic illness as well. We try to, when I showed you that there are mortality as a result from the chronic illnesses, at the same time, there are also increase in incidence of these new chronic illnesses, because all the risk factors are there. If we just take HIV, for instance, because of the lack of antiretroviral therapy, people are dying. But at the same time, there is huge rape, there is a massive displacement, more than 2.1 million people in Tigray are displaced, there is lack of condom. So you can imagine in a place where there is no condom, where there is huge displacement, where there is a gang rape of more than 120,000 women, where actually 5% of them reported that they are infected with HIV out of the people who reported their facilities. You can see the incidence of HIV is going to increase. The same with the other chronic illnesses, because the risk factors are there. So there will be a huge number of people with chronic illness as well. Now, but I can't say that, I can't quantify at the moment. But what I just want to ask a key question to Altafi is, one is with regard to the, WHO surveillance data. It says 0. Is it because of you don't train your experts, or is it because of there is blackout of information, there is lack of communication, so that you don't get? So instead of saying 0, why don't you say just, something, I don't know, whether invalid or something like that? That's one key question. And the second one is, WHO allocated about 128.6 million USD for Ethiopia, out of which 69 is for Tigray. How are you going to send this money to Tigray? Because definitely, if you send through Ethiopia, through Abiy, I can tell you that the money will not go to Ethiopia. So how? Because the bank is closed, the government is the invader, because it definitely, shuts all the services. So how are you gonna send the money to the beneficiaries? Thank you.
Thank you very much, Hailay, and would give the floor to Mr. Altaf to respond to that. But also, I would like to separate between WHO Secretariat and WHO as member states. So this is, I think, important to recognize. And my question also to Mr. Altaf, do you think there is the political climate right now would allow WHO to have meaningful, strong resolution about war, conflict, and health in a way that would address these conflicts we see in a strong way? Here again, I'm not talking about the Secretariat, I'm talking about WHO as member states and the climate, the political climate. Thank you.
Hani, thank you for clarifying that. We as an institution, as you rightly said, are custodians of enforcing what our member states ask us to do. And so for colleagues who are not familiar with that jargon, it's 194 ministers of health around the world who come together in a form and fashion, who push WHO and say, focus on emergencies, focus on health system strengthening, focus on reproductive health care, focus on non-communicable disease, focus on mental health. The list continues to grow And there's a lot of demands placed on us as an institution to be able to define health needs and then help provide the solutions. I'd like to start with the fact that although we are the public health leader in the world, we depend heavily on multiple partners, both within the United Nations system, but equally outside the United Nations system. Healthcare workers such as yourselves, civil society, non-governmental organizations, all of that, in addition to the other non-state actors, makes up the total remit of health actors. And I think one of the things that we do very well is we can bring people together, define a common problem, and then try and convince and coax individuals to all focus on that issue. I think the challenges that you have all cited is there's multiple problems in multiple locations with multiple needs that also in and beyond the health sector's remit. I think one of you very clearly cited that we cannot resolve the malnutrition problem without food security, without food fuel, and without food, and without electricity. All those things must come together. And this is where, at least on the humanitarian side, there is a very clear system to try and push the agencies to work on a common problem. So obviously, if it is malnutrition or if it is a disease outbreak, I mean, again, we have an ongoing Ebola outbreak happening in Uganda. We have cholera outbreaks in 30 countries. And so when governments don't have the capacity or the will, they have, first of all, the primary responsibility to serve their people. And I want to be clear about that. We work in support of ministries of health. As and when they cannot or ask us our support, there are provisions to invoke us and our partners to set up diarrheal treatment centers, to establish Ebola treatment centers, or enable vaccination programs. So whether we bring the vaccine with UNICEF or whether we help train vaccinators, and I think this is a critical point. In the case in point of Tigray, our input has been several. We provide the technical know-how as and when it is needed, and then we provide the operational support. That is subject to, in this conditional, on our partners and ourselves having access. And like many of you cited, we don't have access. And we don't have special access. And so therefore, the Director General, as you said very clearly in the video and in your remarks, has been openly asking for access in Tigray. So that way, not only health activities can commence and expand, but others as well. And if until and unless access is resolved, we will continue to propagate this very dire situation that is spiraling out of control. And so I think it's really important that we bear witness, we keep our hands on what is happening in terms of need, but then we continue to push the advocacy window. And I'd like to stress the fact that, as you mentioned, Dr. Hani, we as WHO are a public health institution. We have a strong arm in health systems development, but of course, my team and myself, as well as our colleagues, represent the emergency side of things. But we do not work alone. We work with you as partners. We work in tandem with you, and hopefully to bring the knowledge. And to your point on surveillance, you're absolutely right. A huge distinction between zero reporting and no reporting, between zero cases, meaning there's nothing out there, or the ability not to report. So we have an indicator in the surveillance which looks at the timeliness and the completeness of reporting. And until both of those are over a certain threshold, then only do we feel confident in the system. As and when they're not, we get worried. So whether it's yellow fever or Ebola, if that is not reported consistently and in a timely manner, we continue to work to provide the knowledge, the know-how, and laboratory capacity to detect. But when it's absent, we become extremely worried. And a lot of us have been saying that whether it's infectious disease, whether women delivering safely, whether vaccination for children, all these things are crumbling, if not non-existent in Tigray. And so therefore, we push that conversation. And I think to your point, Hani, and I close with, this is a conversation that is very much ongoing. We're really, again, grateful to be a part of this conversation, but rest assured, within the humanitarian front, conversations are daily on Ethiopia, on Tigray, and all those other countries that I mentioned. I mean, you can imagine, we focus on 31 countries, but it's not to say that our only input in the world is 31. There's 194 member states. Our 31 is prioritizing those who are the most vulnerable, defined by the United Nations system. And this is, like you said very clearly, places like Syria, Yemen, Mozambique, Central African Republic. Haiti was just about to submit its cholera elimination certificate when it now has a cholera case, after 3 years of being cholera free, after having an earthquake. So we're very careful that each one of those situations is highly unique, highly desperate, and it is our challenge to be able to define the needs within each setting, advocate for them, and as and when possible, in the case of the North in Tigray, push for access as those medicines are sitting in Addis. Access will enable medicines to flow. Access will enable healthcare workers to get paid, but of course, it's also depending on, like you said, the banking system to work, fuel to be present, because we know vaccinators need to go outside the facility. Back to you, Dr. Hani.
Thank you very much, Mr. Altaf. So I would like to invite our four speakers just in a minute to think what PHM can do. What do you think, providing this very complicated situation, providing the silence from international community, and in some cases, there is no way for international organizations to work freely. They are binded by lots of regulations. So what social movements and PHM can do?
I can go.
So I can.
Yeah, you want to go, Dr. Fisra? You want to go ahead?
Okay.
Go ahead.
Yeah. So at least some 50-something people have heard our story. So please act as our ambassadors. I see important people here. So tell our story. Tell it to people, and we can influence world governments and other stakeholders to start helping us. And the core message is we don't have time. You can save children or other patients or HIV patients, TB patients, all kinds of patients who you can prevent their deaths. So the only viable thing I can see is that we, at least those who attended this webinar, can help disseminate this to respective stakeholders, and we can also arrange other similar movements where we can help to reach for our patients, to help them. So future endeavors should be there, but we have also a good number of people who have seen, and then disseminating this recorded webinar is also one mechanism to reach people, as many people as possible, because it's, when you fail a small part in the world, you are failing the world. When you fail one person, you are failing the whole humanity. It's not about the numbers. It's the type of calamity happening. Even if it's happening to one person, the world is failing. So thank you very much.
Yeah, yes, do you want to go?
So thank you again. I think this requires a popular movement, a grassroots movement, and PHN could lead that movement, in a sense that if health workers cannot reach health workers who are suffering, I mean, mind you, they are also victims of this genocide. While serving others, they are dying, and we need to be reaching out to trying to say no to the weak system, international system that we had, that begs genociders to open up corridors for food. Exactly what they are doing, and Mr. Altaf, I don't have hopes that the Ethiopian government is going to open up. And if we are waiting for that system to open, we will be losing quite a lot of people, including some of the health workers that we have. So what needs to happen is the international system. The UN has mechanisms that is established on the war. When a government turns against itself, it fails to protect its citizens, there has to be other mechanisms that need to be invoked, and our work shouldn't have to be begging the government itself, which is doing the crimes. It's like someone who rapes a woman, asking him whether he's he has done it and whether he could repair the damage. It's just not on. So our effort has to go for the other United Nations organizations also to pick up their job and enact some of the regulations that are against using food and medical aid as a weapon to inflict damage on an entire ethnic group. So that has to be escalated rather than still begging and so normalizing as if the suffering that we are seeing in northern Tigray, in Afar and Amhara, is similar to what is in Ethiopia, in Tigray. They are absolutely qualitatively different. So we need to be, that normalizing is not a good idea, because it just makes it lessens what is happening currently in Tigray. So that's first thing. So all who have attended could help us, one, to speak to their politicians wherever they live, to pressure their politicians. This shouldn't happen in the 21st century. People should not be under siege and eradicated while we are seeing in this century, like a medieval period where you put people in a siege and then kill them off. That's exactly what's happening. This shouldn't have to be accepted. We shouldn't have to go on doing that. So if we pressure our politicians, we create a social movement, like some of the movements that we have seen. For instance, Me Too movement has enormous influence on internationally. This shouldn't have to be on. So really, really ask for everyone to do their bit to reach out those Tigrayans in their the places that they live, who are suffering also. I mean, everyone is suffering now. There are mental breakdowns. There are people who've lost their lives outside also. Obviously, Dr. Fasika and others who are inside the war zone are suffering enormously. So let's act as human beings, not allow this to be yet again another story like Rwanda, like the other genocides that have happened to in other places. Thank you.
Thank you very much. Hailay?
A very quick one. I think the take-home message for this webinar, for all the audience, is know that there is active genocide in Tigray. You can read the United Nations Human Rights Expertise preliminary report. If I tell you the summary of it without political correctness, it just simply says, really, that there is active genocide in the region. I am telling you, the diagnosis of their reports. They don't clearly say it, but if you tell me the diagnosis, it just literally says there is active genocide. And so knowing that, every one of you here tell your government that there is the weaponization of health in Tigray. Tell your government that there is, like I said, active genocide in Tigray. So, because if you see still now, officially, the leaders of many countries didn't say any about the war in Tigray, except few agent leaders, such as Dr. Tedros from WHO, and of course, Antonio Guterres from the United Nations. I didn't see many country leaders talking about this one. So every one of you here, tell to your country leaders and politicians about the harrowing situation in Tigray. That's number one. And in specific to PHM, I guess PHM now has got a connection with government leaders, with agencies, as well as also with many experts. So as much as you can, it could be through letters, it could be through the online gallery that you guys are sharing now. It could be through a series of webinars. I think keep awareing the international community, keep pressuring, so that at least there will be a hope for the cessation of hostilities, and then thinking, giving or delivering the medical supplies. So that's what I can say.
Thank you very much. Altaf.
Very briefly, and I just would like to also remind colleagues here that when we as an institution intervene, everything we do is based on the core philosophy, which is governed by medical ethics, but also the humanitarian principles. And I think the humanitarian principles, although people see them as philosophical, this is where they're now being tested in the case in point of Tigray. So whether it's humanity, neutrality, impartiality, independence, those are the factors that we need to be able to do the job we do best, help you do your job. And again, advocating to uphold those principles is important because that's what our colleagues remember. This is why we started this work post World War I and post World War II, is to be able to help those who are suffering. But in order to do so, we need those principles to stand. And I know that they're not standing in this case in point. So I want to be clear, by no stretch of the imagination do we accept normalization of the situation. We advocate very strongly against it anywhere that it happens. Number two, I think, as my colleagues have probably said more eloquent than me, is the bear witness and continue stay the course. We hope that at some stage, whether in days, weeks, months, the guns will fail and fall. And that way will give us an opportunity to create safe space. So that way healthcare workers have the means and people can come out and seek healthcare. Now, it is a very difficult picture, but rest assured that the parts of the system will continue to advocate for that. And as and when we get permission as the WHO and our partners, we will be there. We will be there with the medicines. We will be there with the necessary medical technologies to provide support. We've done it in the past. We are trying to do it now, and we will continue to do it in the future. It's tremendous strain on the system because of the blockades and the restrictions placed on us, but we don't give up. We will continue to advocate for that access so that we can help, one, identify the problem, which you have clearly done, and two, help alleviate that problem. And that's the complicated part, because as we said, if tomorrow we were given access, and I think this is what we should think about, where do we start? What do we start with? Who do we start with? Now, we know as health professionals, we must focus on children and vaccinate them because measles is probably rampant. We also know that there are pregnant women of childbearing age that probably need safe delivery space. We know that there's probably elderly that don't have medicines that they're needed to survive. So the challenge on us is we shoulder quite a large burden. How do we get this assistance in? How is it timely? How is it coordinated? And I think all of that is doable, achievable, if we have access. So the strong appeal to the movement is we must, the Director General said this, there cannot be health without peace, and there cannot be peace without health. It's not just a slogan, it is real. We know that if there is peace achieved, there can be lives saved. And I think we must push that narrative. Thanks, Ken.
Thank you. Thank you very much. I would like, just before we close, to ask my colleague David to just to give us a very quick announcement about the new PHM website. And also, I would like to thank David for the huge effort behind this webinar. Thank you very much, David.
Thank you, Hani. I think, first of all, thank you very much to the four speakers. No, maybe I'm really surprised, and I'm not surprised, but I think it's beautiful to see that a lot of people are reacting and chatting. So there's a lot of involvement, there's a lot of passion, and that's a bit of the point, because PHM, I think a couple of months ago, within the thematic circle of war and conflict, because we believe war, conflict, forced migration, and occupation is a very important determinant of health, that there are a lot of health activists out there, potential health activists that want to do something about a certain case. So this case is, of course, the Tigray case. So that's why with PHM, we constructed an online gallery, and it's something very new. For now, we have like 5 cases from the Philippines, one from Palestine, and this is also the Tigray case. And normally it focuses on one person, an individual case, but this is because it's such a humanitarian crisis, this focuses on healthcare workers in general. So the online gallery focuses on healthcare workers who face or who suffer from some kind of repression from the state or whatever. So I saw some questions also like, what can we do and what should we do, whatever, what should PHM do? So maybe take a look at the online gallery. There's like a little 2-pager on the Tigray case written by Hailay and the others of the Tigray working group. It's like a very short write-up of the case, and at the bottom you can see the campaign on the Tigray case. So for now, we have like a working group of 5 people. The first campaign goal is a visibility. So that's why we are organizing this webinar, because this is a very hidden conflict like Yemen, like Hani said. So this is like the point, no? To share the story, to make it known. So if you're interested, go to the website and contact us and become a health activist and become involved in the campaign on the Tigray case. I think that's a bit of the point. What PHM as a people's health movement, because we are not the WHO, we don't have planes to drop food, but that's something we can do to put pressure to show it to the world, to put pressure to the authorities and stuff. So if you're interested, please go to the online gallery, contact us, and get involved. So that's it. Thank you, Hani, for the moderation.
Thank you very much, David. I wish we have more time, but we exceeded the 2 hours, and I'm trying to be, to be very sensitive to people's time. But just wanted to say that we have quite a strong circle as one of the thematic circles of PHM around war, conflict, and health. Also, there is a new global coalition around that. So if you want to join us and let's work together, please contact our global secretariat to be part of this thematic circle. Again, I would like to thank everybody participated in this webinar and thank our speakers. And this was a very strong webinar. The recording will be available online. We will also try to make quick summary if we can from the very rich chat and comments, and put them with the video as well. So thank you very much, everybody, and we'll close the session now.
Thank you, Hani. Thank you, David, and Fasika, Altaf, all. Thank you very much. Thanks, PHM.